Ashir, you can see my screen?
Yes, ma'am.
Yeah. Good evening, everyone. I am Dr. Sailaja from Vijayawada Society. Today we are meeting here due to the hard work put in by Dr. Kumari to enlighten us, educate us about the new MTP Amendment Act, which was brought in September 2021. I am going to tell you about the amendments in the Act, and my next speakers will go ahead with the further sessions. Slide is not changing. Yeah. The objective of this first module is disseminating evidence. We'll be taking a closer look at what the new laws are and what are the changes in rules since the last MTP Act. Unfortunately, unsafe abortions in India have led to a lot of mortality, morbidity, and have hampered women and girls' full participation in any activity in the society. 8% of maternal deaths per year are due to abortions, and this is the third leading cause of maternal mortality rate, and nearly 2 out of 3 of the abortions performed are deemed unsafe. This is what we want to change. Nearly half of the pregnancy-related deaths are in women and girls under 24 years. That's so pathetic. When do you consider an abortion safe? According to WHO definition, an abortion is considered safe when 2 criteria are met. It should be done by the appropriate methods and it should be done by trained persons. It is not considered safe if it is done by untrained people and not done by appropriate methods. If only one criteria is met, it is considered as less safe. Ideal situation is it should be done by appropriate methods and by trained persons. In 2021 September, the MTP Amendment Act was brought and safe and comprehensive care was mandated by law in India. Let us see what the salient features of this amendment is and what are the differences from the previous act. Modification was brought in the requirement of the provider. Previously, we required the opinion of one provider for MTP up to 12 weeks, and from 12 to 20 weeks, we required the opinion of 2 registered medical practitioners. According to the 2021 amendment, we require the opinion of only one registered medical practitioner for termination up to 20 weeks of gestation. And we require the opinion of 2 registered medical practitioners for termination from 20 to 24 weeks of gestation. So what is the potential outcome of this modification in the Act? There is increase in the number of facilities, especially in public sector like PHCs, where a single doctor is available. They will be eligible for providing these abortion services until 20 weeks. Hence, abortion services will be more accessible to women. Registered medical practitioner definition is as per rules, which will be elaborated later. The modification for the vulnerable group of women. Previously, MTP was permitted only until 20 weeks. And that too only when it is immediately necessary to save the life of the pregnant woman. Now, in the amendment, the upper limit of gestation is enhanced from 20 to 24 weeks. But here you must remember, 20 to 24 weeks you can terminate only in special vulnerable categories of women. And further, enhancement has been done for birth defects not compatible with life on consensus of medical board formed in all the states. What is the potential outcome of this? There's increased access for vulnerable women like widows, or a woman has got pregnant and now she is divorced, she wants to terminate her pregnancy. Such groups of women, there's increased access for safe and legal abortion services defined by rules committee, like violence victims, the pregnancy as a result of rape or incest, pregnancy in a minor, pregnancy in a calamity declared as emergency by the government. In such vulnerable special categories of women, termination is permitted between 20 to 24 weeks. The modification brought for birth defects and congenital anomalies. Previously, the Act had provision for termination of such pregnancies with birth defects only up to 20 weeks. But now the upper gestational age limit is not there if there is a substantial fetal abnormality which is confirmed by a medical board and they give permission for termination of pregnancy. You can terminate the pregnancy up till any gestational age. This has brought in an increase in access to safe and legal abortion services for those who often seek service late beyond the legal limit for termination with substantial fetal anomalies. If you remember previously, if the pregnancy was beyond 20 weeks and there was a substantial fetal abnormality, the patients used to go around courts, and by the time the result came, she would be nearing term and we had to deliver a live baby. Now that has changed. With the permission of the medical board, we can terminate pregnancy up till any gestational board permits, reducing unsafe abortions and court cases. There is insertion of a new clause for strengthening privacy in the new Act. Previously, the MTP Regulation 2003 states that information should not be disclosed except under authority of law. The new insertion is name and other particulars of woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being enforced. That means you should not be writing the name of the woman seeking abortion in any paper which will go out of your clinic. Only your admission register will be having her name and that must be kept under lock and key. This has increased the privacy and confidentiality of abortion seekers, increased demand, but need to safeguard the rights and dignity of the woman and provide respectful, bias-free services, including counseling and contraception services. The salient features of the law MTP Amendment 2021 are: it is prioritizing confidentiality and safety of the woman. Name and any other particular of that woman seeking abortion is to be kept confidential except to a person authorized in any law for that time being in force. And the ground of failure of contraception has also been extended to unmarried women and their partners. Previously, this was permitted only in married women. Now we can terminate pregnancy on the ground of failure of contraception even in unmarried women. Under the MTP Amendment Rules 2021, they have defined the special or vulnerable category of women eligible for termination from 20 to 24 weeks. They have defined the norms for the registered medical practitioner whose opinion is required, single medical practitioner until 20 weeks, 2 medical practitioners from 20 to 24 weeks, and the powers and functions of the medical boards, which is constituted by an obs-gynecologist, pediatrician plus radiologist when available, formed for each state and mandated to provide timely evidence-based decision to terminate pregnancy beyond 24 weeks when it is necessary. One second. Yeah. Under the MTP Amendment 2021, the special category of women who are eligible for termination of pregnancy between 20 to 24 weeks are women with physical disabilities. Here the major disability as per criteria under the Disability Act. Any change of marital status during the ongoing pregnancy, like woman has become pregnant, during the pregnancy she becomes a widow or gets divorced, or a woman with pregnancy in humanitarian settings like any disaster or emergency situations as declared by the government, any survival of sexual assault, rape or incest, any mentally ill woman including mental retardation, any minor, and if the fetal malformation has substantial risk of being incompatible with life, or if the child was born, it would suffer from major physical or mental disability and would be seriously handicapped. Point number 2 under the rules is definition of the registered medical practitioner. In the old act, it has been MBBS or more with any experience of assisting in 25 cases of termination, of which at least 5 are done independently in a hospital, or a medical practitioner who has completed 6 months of house surgency in obstetrics and gynecology, or a medical practitioner who holds a postgraduate degree or diploma in obs-gynae, or who has experience of at least 1 year in the practice of obs-gynae. As I have told you, up to 20 weeks of gestation, opinion of such single registered medical practitioner is sufficient. From 20 to 24 weeks, opinion of 2 registered medical practitioners, but applicable only in the special or vulnerable category, and beyond 24 weeks with the opinion of the medical board. And under the amended rules, an additional category of provider has been added. For termination up to 9 weeks, which is permitted by the Government of India with medical methods, any registered medical practitioner with experience in obs-gynae at any hospital for 3 months is sufficient, or they have had training with performances of 10 cases of MTP by medical method of abortion under supervision of a registered medical practitioner in a hospital established, maintained, or a training institute approved for this purpose by the government. Previously, this experience was 6 months and the training was required for 25 cases. Now, for only medical methods of abortion, this has been reduced to 3 months and training with performance of 10 cases of medical methods of abortion. And the norms for the registered medical practitioner whose opinion is required for termination of pregnancy at different gestational ages till 12 weeks. Experience and training requirement for the registered medical practitioner is a practitioner who has assisted a registered medical practitioner in the performance of 25 cases. For only medical methods, it is 10 cases. For until 12 weeks, it is 25 cases, of which at least 5 have been done independently in a hospital. This is as before. Or a practitioner who holds a postgraduate degree in OBG, or who has completed 6 months of house surgency in OBG, or who has experience at any hospital for a period of not less than 1 year in the practice of OBG. This everything is as before, but the only thing which has changed is opinion of only 1 registered medical practitioner is required until 20 weeks of pregnancy. For, beyond 12 weeks till 20 weeks, practitioner should be either holding a postgraduate degree or diploma in OBG, or completed 6 months of house surgency, or experience at any hospital for period not less than 1 year. Here, an MBBS person is not allowed to do the termination. That we should understand. Beyond 20 weeks till 24 weeks, the norms are the same, but vulnerable special group and the opinion of 2 registered medical practitioners is required. And what is the composition of the medical boards whose permission is required for termination beyond 24 weeks? These comprise a gynecologist, a pediatrician, and a radiologist or sonologist. They can also add on other specialties as and when required. Like suppose the fetus has a cardiac abnormality, the opinion of a pediatric cardiologist can be taken to decide whether we can terminate the pregnancy or not terminate the pregnancy. What are the powers of these medical boards? They can either allow or deny termination of pregnancy beyond 24 weeks of gestation only after due consideration and ensuring that the procedure would be safe for the woman at that gestational age, and they have to decide whether the fetal malformation has substantial risk of being incompatible with life, or if the child is born with that abnormality, whether there will be serious physical or mental abnormalities for the child to be handicapped. They can, as I told you, they can co-opt other specialists in the board and ask for any additional investigation if required to decide whether or not to give the permission for termination of pregnancy. And FOXI, with the guidance of the ministry and WHO support as part of this respectful abortion care, is helping us in operationalizing and hosting medical board information on the website. What the functions of these medical boards? They have to examine the woman who has applied for abortion and her reports, provide the opinion in Form D whether we can terminate or whether they'll reject the request for termination within 3 days of receiving the request. This is important. The medical board has to give an opinion within 3 days of receiving the request, and also they have to ensure that the termination procedure, when they have allowed termination, is carried out with all safety precautions with a 5 days of the receipt of the request for termination of pregnancy. FOXI has an important role to play in ensuring there are functional medical boards in every state, as is stated in the MTP Amendment Act. Previously, patients used to go around the court with or without help, and the decision used to get delayed. Here, the time frame has been fixed. The opinion has to be given within 3 days, and they also have to make sure that the termination is completed within 5 days of receiving the request from the woman. Here is a reminder again for your post-test and feedback. Just as you did your registration and pre-test, only after submission of this, you'll be getting this certificate about this MTP RSC program. Let us make it safe and respectful. Samarth sustain, accelerate mainstream access to reproductive health through the health system. So let us make sure Samarth Bharat, Sampurn Bharat. Thank you for your patient hearing. Good evening, Ajay sir.
Thank you so much, ma'am. It was a wonderful and brief presentation.
As I understand, this is the Indore Society, right?
Yes, sir.
Yes, sir.
Okay, where is Jyoti?
Dr. Jyoti Banglowala.
Jyoti Banglowala. I can't see her.
Yes.
Hello, can you hear me?
Yes, sir, we can hear you.
Okay, I think Jyoti Banglowala has not joined. Please give her my regards and do let her know I was asking about her.
I have a question in the chat box, sir. Can I address that?
Yeah. Sorry?
Yes, sir, I have a question in the chat box. I would like to address that. Somebody is asking me whether when the opinion of 2 registered medical practitioners is required, whether one person has to be in government service. That is not necessary. I told you about who is a registered medical practitioner. They need not be in government service. It can be anyone. They only have to fulfill the criteria which we mentioned for registered medical practitioner. Dr. Rekha, who is taking the second topic? Somebody is asking what is the rule for giving medical pills to unmarried women more than 18 years. More than 18 years doesn't come under the POXO Act, so you can as well take a consent in Form C and give her the medical pills. Single consent of the unmarried woman more than 18 years is sufficient to do medical termination of pregnancy. Ajay sir, I don't remember who the second speaker was.
1 minute.
Dr. Lakshmi Srikande is here.
Yeah, but I am taking the third talk.
Second topic. There's one more question in the chat box. Beyond 20 weeks, termination allowed in only in special vulnerable groups? Yes, 20 to 24 weeks only in special vulnerable groups. And whether both RMP should be registered with the hospital for MTP beyond 20 weeks? The hospital should be registered for conducting termination of pregnancy. That registered medical practitioner can be a part-time consultant at that hospital. I hope I'm clear.
Yeah, the second speaker for the day was Krishna Kumari. She was in the other group right now, a while back. I don't know, I can't see her right now. No, I don't see her.
No, sir, she hasn't logged in.
Okay. We'll try to get to her. In the meantime, maybe we can start off with the third presentation. Lakshmi, is it okay?
Yeah, it's okay with me.
Yeah.
I can start. So,
Lakshmi madam, 1 second. There are some more questions in the chat box.
Okay.
You mind if I address them first?
No, no,
yeah,
please,
please go ahead.
Should records be maintained for medical abortion also? Absolutely. Record has to be maintained for medical termination of pregnancy also. When you don't adopt any surgical method also, you have to maintain the record. And if pregnancy is caused by rape, do we need to inform police? We need to make an MLC, give information to the police, but FIR is not mandatory. It is the option of the woman whether she wants to complain or not. When we send information to the police station and just take acknowledgement from them, there ends our job. Lakshmi madam, go ahead with the third presentation.
Okay, Dr. Sailaja. So, host has disabled participant screen sharing. Please allow me screen sharing meeting.
Yeah, 1 minute.
Yeah.
Give me half a minute, please.
Yeah, no problem. Or you can make me co-host so that I can share.
Somebody is asking to repeat the slide on special vulnerable groups. I can't repeat the slide, but let me tell you, it includes women with physical disability, change of marital status, whether a widow or a divorce, in calamities like emergencies declared by the government, pregnancy as a result of a rape or incest in a minor, mentally handicapped person, and when there is a fetal abnormality incompatible with life or likely to cause serious physical or mental disability in the child.
Yeah, so thank you, Dr. Sailaja. I am taking this third module for the participants, and this module is on safe abortion, values, evidence, rights, respect. That is the SAVOR module. This module aims to define what is respectful abortion care according to WHO standards. It also highlights how norms and stigmas are affecting our RAC services, and to provide you all with WHO SAVOR resources for respectful abortion care. Now the momentum for this has been created. Our law has been changed, you all know, but we need the dissemination through our associations, and we all have to garner the support of each and every OBGYN specialist. We all know that FOXY is the largest provider base for abortion care with around 38 to 40,000 members across India. Online training is now possible due to COVID. It is a blessing in disguise that we all have been connected to the digital platform, and this digital platform has given us opportunity to reach out to the nook and corner, to reach out to the each and every FOXY member as far as providing respectful abortion care is concerned. MMA uptake has also increased. We want to have early, safe, and please ensure that we do not have any conflict with the PCPNDT rules. Patient safety, respect, and quality matters more than ever, and we all, each and every OBGYN has a role to play towards this respectful abortion care. So what is this respectful abortion care? This is adopted from respectful maternity care, which is recommended by the World Health Organization. The respectful abortion care refers to care that maintains safety, dignity, confidentiality. It ensures freedom from harm and mistreatment, and it enables informed choice and continuous support during and after all types of abortion. So each and every word here is important. what constitutes respectful abortion care? So these are the components of respectful abortion care. In simpler terms, respectful care means you as a provider treat and or treated, it is applicable to both provider and patient, that you should be able to treat, and if you are a patient, you should get treated with dignity, empathy, and compassion, regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. This is very, very important for we all OBGYNs to understand. If you ever feel that something is not right, speak up. As health professional, it is our duty to listen and support. Remember, communication is the key, but it has to be a dignified, confidential counseling with the patient. Now come to the second component of respectful abortion care. So what are norms and stigma which can affect our respectful abortion care? So the stigma and norms, they perpetuate disrespect and abuse. And I'm sure you all will agree with me that our own stigma sometimes gets translated into our patient care. So the category of disrespect and abuse, first is physical abuse, that is slapping, that is intimidating physically. I know in this era, it's a very, very rare type of stigma, but yes, at some places, women can be subjected to physical abuse. The second stigma is verbal abuse, where there is a non-consented care, the provider shouts or screams at the patient. The third is sexual abuse, that is abuse of power or taking advantage of the vulnerable situation of that pregnant woman. Now I will be showing you stigma and discrimination, that is saver videos. Ajay, you want me to show here or after the slide? The fifth stigma, yeah.
Okay, good when it comes up with the slide, Lakshmi.
Yeah, I will finish the slide and then you will share the video. Yeah. Failure to meet the professional standards of care is again another form of stigma. Poor rapport between you as a care provider and with your patient. And sometimes I know in the public system, there is a lot of crowding, there is overflow of patients, and health providers, they are short of time to give adequate time to counsel this pregnant woman. So these are the constraints of the healthcare system. But remember, every woman has the right to have freedom from harm and ill treatment. Every woman has a right to information, protection under laws, that is MTP and POCSO Act. She has right to informed consent and refusal. And here we providers have to respect her choice. Respect choices, preferences, dignity, and quality of care. This is right of every woman. Along with this, every woman has the right to timely health care and to the highest attainable level of health, liberty, autonomy, self-discrimination, and freedom from coercion. So as a healthcare provider, we should address our own stigmas on one hand, and on the other hand, we should know what are the rights of every woman who has come to us for abortion services. So,
if
Ajay,
somebody is available, fine. Otherwise,
somebody is doing annotation, and you can show the saver video here. Yeah. Should I stop screen sharing? Ajay?
Yeah, sorry. I was on the other.
You want me to stop screen sharing so that you can show saver video?
Yes. Go to the next slide. You don't have it automatically running there?
No, it is not running automatically when I am clicking. No.
Okay. Just stop sharing. Yeah.
Yeah, I will stop. So we will be showing you a video so that it will make my points more clear to you all. We will answer your questions. Just wait, let me finish my presentation. Yeah. In the meantime, you all can post your queries in the chat box.
Ajay sir,
Yeah, Ajay is sharing that video, saver video.
Yeah. 1 minute. I've just
Yeah, yeah.
downloaded it. Shailaja, just give me half a
sir,
minute.
Padmaja madam is free. She is ready to take. She is logging in. Can you send her a link?
1 minute.
Yeah.
Just hang on. I'll first play the video for the benefit of everyone, and then I'll do that bit. Okay. Hang on a second.
Dr. Sailaja, in the meantime, can you answer this question? Can you elaborate on abortion record keeping? Yeah. Okay, we will wait. Ajay, please play the video. Yeah.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO SAVA, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic,
We have lost audio, Ajay.
standalone games to learn from the comfort of your home. SAVA has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. SAVA is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
Yeah, so I will share my screen again. So what are the domains of respectful abortion care? There are 12 domains. First is being free from harm and mistreatment. Second one is maintaining privacy and confidentiality, preserving woman's dignity, respecting her choices, engaging her with effective communication, and here soft skills are very important, providing information and seeking informed consent, ensuring continuous access to support, enhancing quality of physical environment and resources, providing equitable abortion care, availability of competent and motivated providers, provision of contraception advice and commodity security, and continuity of care and counseling. So remember these 12 domains towards providing respectful abortion care. Now it is time to strengthen the implementation, because we all know the theory part. So how to strengthen implementation at the level of each and every care provider? I know one provider, we have many responsibilities, that is counseling her, providing her contraception services, referral and compassionate care. 20 to 24 weeks, these belong to special cases category. You have to have very sensitive towards their needs. You have to be judgment free and provide timely services. You have to prioritize confidentiality and safety. So you have to be mindful of the socio-cultural aspects. How to avoid the stigmatizing language? I think, Ajay, here there is a video.
Yes.
Okay.
You can stop sharing.
Yeah, I will stop sharing.
Give me half a minute.
Yeah, yes.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or registered medical practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome, which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro-life implies that those who support legal abortion access are anti-life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights-based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business-related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, What is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework, but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the three P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
Yeah, so this was a very, very educative video, because sometimes unintentionally we use some words which are not right. So this video has highlighted the importance of the correct words which we should use when we are providing the respectful abortion care. So now, from the domains of respectful abortion care, time to strengthen the implementations, we have given you guide how to avoid the stigmatizing language. And again, I think there is a video here, Ajay, for this WHO training for safe abortion values, evidence, and right. I think there is a saver toolkit video here.
Yes,
Ajay?
let me just play that for you.
Yeah. Yeah, there is a video. Because when we download, it is not playing when we click on the video from our end.
I'm surprised because that's exactly what I'm doing. I don't
Yeah.
have it on my file.
I don't know, but at my end, I'm not able
I
to.
just downloaded them while you were talking.
Okay.
I'm also doing exactly the same thing that you are doing, you know?
Okay, I have not downloaded.
Maybe. Yeah, you have to download them.
Yeah.
Without that, they will not play.
Yeah. So you are playing this video now?
Yes, please. One
Yeah,
minute.
please. Thank you.
That's the one, right?
Yeah.
Okay. And we have Krishna Kumari also joined in. Thank you so much. And Sailaja, a huge thank you to you before I start playing. You know, you in the background organized everything. I don't know if Sailaja is there, but thank you so much for arranging Padmaja in the meantime. But we have the original speaker back. Thank you so much, Krishna Kumari.
My pleasure, Dr. Dr. Ajay, Mr. Ajay. I
Social
think I
norms
was
are the unwritten rules of behavior that are considered acceptable in a group or society. Norms can change according to the environment, situation, and/or culture in which they are found. People's behavior may also change accordingly. What are some examples of social norms? In times of COVID-19, there are new social norms that are considered COVID-19 appropriate behaviors like wearing a mask, maintaining social distance, and to wash or sanitize our hands regularly. An example of a social norm that we must follow at all times is to not use profanity in conversation, especially formal or official conversations or when talking to patients, clients. Now let's look at some examples of social norms around gender. Girls wear pink, boys wear blue. This is a gender stereotype. Girls and boys can choose to wear whatever color they like. Color has no gender. Men should be working, strong, and not show emotion. Women should be caring and nurturing and stay at home. Men should work and make money. Women should take care of housework and children. There is no need for women to own or inherit property. Now let's look at a few examples of norms around sexual and reproductive health. Just as norms around gender are smaller aspects of some broader social norms, norms around sexual and reproductive health also trickle down from certain norms around gender. According to the WHO, good sexual and reproductive health implies that people are able to have a satisfying and safe sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. A woman should be married before getting pregnant and having children. Adolescent sexuality and premarital sex are unacceptable and immoral. Women are responsible for contraception. Now we see what is stigma. Stigma can be understood as a shared understanding that a person, a quality, or circumstance is somehow morally unacceptable. What are examples of sexual and reproductive health stigma? A shared understanding that sex before marriage is morally wrong and or socially unacceptable. A girl who uses a contraceptive method is promiscuous and will have problems when she decides to get pregnant. A married woman is more deserving of contraceptives than an unmarried woman. A girl who has had an abortion is committing a sin and brings shame to her community. Having an abortion has long-term health effects, and the woman's health will never recover to her pre-abortion state. Women who have had an abortion once would become habitual and avoid using contraception. It is important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, sex selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
Yeah.
Yeah,
So it
you're
was a self-explanatory video where the norms and stigma have been explained to us in a very, very detailed manner. So these are the links where you all can go and you can have these Saver Toolkit details. And from 1970, that is from the era of unsafe abortion, to 2000, which we call as an era of safe abortion, and now 2020s, we are talking of respectful abortion care. So according to the WHO, restricting access reduces the number of unsafe abortions. This is for all of you to answer, true or false. According to WHO, restricting access reduces the number of unsafe abortions. Kindly post your responses in the chat box. So this is the answer, that restricting access reduces the number of unsafe abortions is false. This is another question for you all participants. The MTP Amendment 2021 Act requires a minor who is less than 18 years to obtain written consent from parents before she can undergo a termination of pregnancy. True or false? Now, in this recent MTP Act, where a minor needs consent of parents, it is false, because if she is less than 18 years, she does not need a written consent from parents before she can undergo a termination of pregnancy. But here you all should know that POCSO Act requires reporting because she is less than 18 years. So you have to report to the police, but abortion services should not be denied to her just because she is less than 18 years of age, because as a service provider, we have to provide bias-free services without any judgment. For minors, consent can be given by any guardian, and providers must not insist on parent and should not restrict access to safe abortion services for those girls who are less than 18 years of age. It is emphasized that consent for below 18 years is mandatory, and POCSO reporting as per protocol must continue, yet services of respectful abortion care must not be denied to her as per the MTP Amendment 2021. This is another question. 30-year-old recently widowed wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? At 22 weeks, will you tell her to continue pregnancy? The answer is no, because it is not in our domain to be judgmental, or we are supposed to provide bias-free services. So as per the new amendment, with 1 RMP, you can provide up to 20 weeks of termination. If she is 22 weeks, so between 20 to 24 weeks of gestation, there has to be 2 registered medical practitioners, and you can go ahead and provide her with the respectful abortion care. So friends, this was all about the components of respectful abortion care, how we all should be non-judgmental, how we all should provide respectful abortion care without any bias to all the women who are seeking abortion services from us. If there are any questions, please post in the chat box. Yeah, back to Ajay.
Yeah, I mean, I think the society team needs to take over. I'm just here to be of help. I don't know who's from the society leading the entire show here. I don't know. Nobody seems to be answering. Anyway, so let me then carry on. Yeah, so it's wonderful. Thank you so much, Lakshmi, for talking to us on this important topic. I don't know if there are any more questions in the chat box which we need to address, or we can straight away get on to the next one.
See any questions? I think this presentation along with videos is really a very, very self-explanatory module of this RAC program. And I'm sure everyone is crystal clear how they should integrate this respectful abortion care module into their practice.
Yeah, certainly. So with those words, let me invite our next speaker, Krishna Kumari, Dr. Krishna Kumari, who has joined us. And there was a bit of miscommunication, and which we have sorted it out, because that's the reason for the delay that she had. And I'm really thankful to her for having taken the time off. And once again, logged in to join all of this. And also thank Shailaja in the meantime, who was trying to organize this entire bit in case, Krishna Kumari had to go in for some kind of a last minute, emergency. With those words, I'll request you please carry on with your presentation. Thank you so much.
Thank you. Thank you so much, Ajay. It's again a very good evening to all of you. And I think we have already been sensitized in quite a number of points. Can I share my screen?
Yeah, you have already been made the co-host.
Okay, great. So is my screen visible? Yeah.
Yes.
Audible? Okay. So this is a second module where it talks about the updates in technology, and it is going to cover what are the existing guidelines and how to assess the patient before the abortion process has started. What are the different medical and surgical methods of abortion? That's what we're going to cover in this topic. And we all know that there are a lot of guidelines, global guidelines on safe abortion by WHO, but there are huge books which need a lot of time and effort to go through them. So what exactly happened was the WHO, in collaboration with FOXI, and of course have come together, and they have given us a very concise way of bringing in the newer laws and the newer methods to all of us in a more focused way. So the WHO national publications are also have been there rather than the global publications over time. They have been started from 2012 to 2019. A whole series have been released. And if anybody has the time and interest, please go through all these books which are available on the net. I've seen a few of them, and they're quite interesting to read. And most importantly, we are now aware of the law, the newer laws that is the Ministry of Health, Family Welfare National Guidelines. That is what we are supposed to be very focused upon. And it was really a historic change which has come about in 2021, and it has made brought in many interesting points which we were all as clinicians confused and having a little gray zone, are now being more clearly brought about by this law. Although the law was changed in 25th March, it was the rules have changed in 24th September, and now it is gazetted, and this comprehensive care is mandated by law. And that include three key areas in management, that is the pre-abortion care, the care methods, as well as the aftercare and follow-up, which I think Dr. Lakshmi Shrikande has already sensitized you all about to some extent. You were followed by the post-abortion contraception and counseling. So it's very important. The most important point in termination of a pregnancy is the decision making. And this we have to do it in by putting all the different aspects together. First being the medical history. And in the present days, we see many a times the gynecological examination missing, which should not be missed. A physical examination is mandatory. And laboratory and other investigations, some of them have shifted from being mandatory to be done only if it is available. And of course, discussing the contraceptive options as and when we get an opportunity is very important. And she should be able to choose. We should counsel her in such a way that it is her right to choose from the different methods which is the most appropriate. We guide her and she chooses. So that is how I would put it, based on the duration of a pregnancy and a medical condition. So what is it? What is included in the recent pre-abortion assessment and counseling is, like we already know, that a detailed history taking, a general examination, a pelvic examination, labs, and decision making, followed by counseling regarding the appropriate method. how to calculate gestational age by different aspects, whether it's by history taking or by clinical examination, and what are the different aspects where we can go wrong. So these things are already been, I think we are all experts in this. How to calculate the gestational age is our bread and butter, whereas how to go about whenever we go wrong, like for example, the height of the uterus is not corresponding to period of gestational age, what is the differential diagnosis when it is more or when it is less, whether it's the wrong dates or something else which is there. All these are clinical aspects which have been time and again practicing in our regular practice, and I'm sure all of you are very thorough about this slide. So now coming to what has changed is in pre-abortion investigation, they have said that routine lab tests are not a prerequisite. Again, I would say they are not a prerequisite for abortion services. It does not mean that they're restricting you from doing any investigation which you think is essential, but these lab tests are not a prerequisite for abortion services. So what are other than the physical examination, they recommend a pregnancy test. If pregnancy has not yet been confirmed, do a hemoglobin and a hematocrit, especially if you suspect anemia, and especially if we want to be able to give RH immunoglobulin, please look at the blood grouping and RH typing. And HIV testing and counseling should be done whenever the opportunity arises, along with the STI screening, which is mostly done by excluded by doing a pelvic examination. And if there is any medical issues, you can go ahead and do other labs which are needed for either the kidney or liver function tests. So the biggest query which we keep getting time and again when we are making this presentation is regarding the ultrasound. They have not said that do not do an ultrasound. What they said is ultrasound is not necessary unless you have to diagnose, you're suspecting an ectopic or a miscarriage or something not fitting into a regular healthy pregnancy. Then otherwise they say it is not mandatory to do always an ultrasound. That's exactly what they are trying to bring in this by this slide. Then as far as the counseling is concerned, you need to ask about the patient, talk to the patient, ask her about what her thoughts are on about terminating the pregnancy, then why she is terminating her pregnancy. Then it is our responsibility to inform her that early abortion is safe. There is a need for a trained provider, and you need to have as we have already seen in the previous module, the provider and the procedure and the place all have to be appropriate, and they have to be safe, and they have to be already been legally acceptable. And available methods of abortion, what are the different methods which are available, and what are the risks and warning signs when the abortion is happening. And without contraception, we have to enlighten her that if she's not going to use a contraception, within 14 days after doing an abortion, she is likely to ovulate and again have a pregnancy. And when she can resume her normal activities, including sexual intercourse and any other special follow-up care which she is wanting. Then what needs to be documented is an informed written consent and a decision to accept post-abortion contraceptive. But then again, if you're not willing for contraception, it is not a reason for you to deny her the abortion services. It is your responsibility to keep at every opportunity, you please counsel her that there is a need for contraception, and every time, but then if she denies a contraception, you cannot deny an abortion. But make use of opportunity at every possible time to enlighten her. And then coming to the clinical management, this is a slightly different from global and Indian, because as per the global recommendation, medical termination has been,
मैं ऐसा नहीं करता हूं, मैं कैसे उसका बताऊं कैसे है तुम्हारा अकाउंट.
As per the global recommendation, we can have up to 12 weeks of, they go for medical termination up to 12 weeks, that is mifepristone and misoprostol. Only misoprostol regimens are there, as well as vacuum aspiration. And after 12 weeks, it is again mifi and miso or misoprostol and dilatation and evacuation. And of course, we all know that sharp curettage should not be done. So no dilatation and sharp curettage to be done. But the government of India recommends that medical termination should be done only up to 9 weeks. There's a slight difference in the when the termination is done up to 7 weeks or between 7 to 9 weeks in the dosage of misoprostol. But basically, you have to understand medical termination as per GOI is recommended only up to 9 weeks of gestational age. Then in the first trimester, we have the medical methods as well as both the surgical methods, whether it is manual or electric vacuum aspiration. So the most important drugs for us in medical methods are the mifepristone and misoprostol. Mifepristone, an antiprogesterone, which inhibits action of progesterone and interferes with continuation of pregnancy, whereas the initial oral dose of mifepristone is later followed by a misoprostol, which is a prostaglandin E1 analog, and also causes cervical softening, uterine contractions, and expulsion of products of conception. So both of them work together hand in hand in helping us. And the dosage. So mifepristone is administered on day 1. 200 milligrams is given orally. And if the patient is Rh negative, you can supplement, you can also give anti-D 50 micrograms on the same day. And day 3, we give a mifepristone followed by misoprostol. So up to 7 weeks, 400 micrograms of misoprostol, that is 200 micrograms, whether sublingual, buccal, vaginal, or by oral route can be given. But when it is between 7 to 9 weeks, you give 800 micrograms sublingual, buccal, or vaginal. So up to 7 weeks, 400 micrograms of misoprostol is sufficient. And after 7 to 9 weeks, 800 micrograms of misoprostol is recommended. So along with the misoprostol, you can give analgesics, you can give antiemetics, and also take the opportunity to offer her contraception. And you ask her to come to you for follow-up on day 15. And that day you confirm that all the products have been expelled. And if you have not, she's not accepted yet, you please offer her contraception once again. So you have to ensure that there is completion of the procedure and offer her contraception on when she comes back to you after 2 weeks. So what is the difference in the different routes? Oral route is when they swallow, buccal or sublingual. But the disadvantage with these different routes is that there can be side effects like diarrhea, nausea, fever, chills, vomiting. And the fastest onset of action is seen with sublingual and with the highest plasma concentration levels. So side effects also might be relatively higher. The vaginal, they are placed in the vaginal fornices and she is instructed to lie down for 30 minutes. The advantage is that the side effects are the lowest with the vaginal route, but there might be some pill fragments which may be visible and expelled. So buccal and sublingual are the other forms of giving oral misoprostol. So when we are coming to the WHO drug regimens, the dosage schedule goes like this. This is a global recommendation, less than 12 weeks, 200 milligrams of mifepristone, followed 1 or 2 days later by 800 micrograms of buccal per vaginal or sublingual misoprostol. They also have a separate regimen that is only misoprostol regimen, which is an alternative regimen where they give 800 micrograms directly without using the mifepristone. So normally we all tell our patients that for 2 weeks there can be some amount of bleeding even after medical abortion. And in very rare cases, this bleeding can last up to even 45 days. So it is very important that these services should be available at the primary care level with referral systems in place whenever there is a requirement to higher care level care. So additional services at the same time, you should also be able to provide counseling, testing for HIV, abuse support services, psychological or social services, or other specialist health or medical services. We should be able to provide all these to that woman, and especially in the primary care center. So up to 9 weeks, medical termination can be done by a single doctor at and all the people who are eligible, all the RMPs have been very well defined in the first module. And so the main purpose of this is for all people at primary care level, a single RMP can do this termination medically. And at the same time, see that additional services are again available. Give her iron tablets if she's anemic, and any other pain, if you're thinking that she'll have some pain, give her some pain relief medications. And most importantly, it's necessary that you provide her with emotional support. And follow-up care, routine follow-up is not necessary if after an uncomplicated medical abortion when you use both MIFI and MISO. But when those cases where only misoprostol has been used, is where the chances of incomplete expulsion of the products is more likely. So you need to follow up with these patients after 2 weeks. So usually the follow-up is done 7 to 14 days after the procedure. And you again take an opportunity to provide her with contraception as well as other services like emotional support, or any other medical concerns can be addressed. And you also can assess women's recovery and ask for any signs or symptoms of ongoing pregnancy. You review any available medical records and referral documents. Ask about any symptoms experienced since she had the procedure. You do a focused physical examination if she has any complaints. And of course, very importantly, you have to talk to her about what her future fertility goals are, and if needed, what contraceptive services, if they have not been provided earlier, should be now addressed in the follow-up care. So the medical methods of abortion include a physical pelvic examination, confirm eligibility, whether it is 6-7 weeks or more, give tab MIFI, and offer anti-D if she's Rh negative. Ask her to come back for MISO after 2 days. Contact address and phone number of the facility center if there's any emergency should be provided, and record her experience of any side effects on medical methods. And 3%, even with MIFI alone, they will expel the products. Even though they have expelled the products MIFI, you have to provide them with complete the misoprostol schedule for these women. And on the second visit on day 3, you give her misoprostol 400 micrograms sublingually, buccal, vaginal, oral. Observe for 4 hours. Give ibuprofen 400 if you for analgesia, and again talk to her about the contraceptive options. Then tell her that the bleeding can last for up to 2 weeks. There can be nausea, vomiting, diarrhea, headache, fever, dizziness because of the tablets. And if there is excessive bleeding, pain, or fever, she should report to the center for contact which you have given. And report if there is no bleeding even after 24 hours of MISO. Again, she has to come back to you. So usually most of them, 75%, they do abort within 4 to 6 hours after misoprostol. Then the third visit is the review visit after 2 weeks, when you do a pelvic examination to ensure that the products have been completely expelled, the cervix is closed. Talk to her about contraception, whether it's hormonal, condoms, IUCD, or sterilization. Tell her about immediate return to fertility. Report back if there are no periods within 6 weeks of completion, and ultrasound should be done if you are not very sure that the procedure has been complete. Then the side effects and complications, we have already said the pain. So for pain, you have to first, most important, be non-judgmental and respectful, give her verbal support, counsel her, support her. There should be a person who will support her, give her ibuprofen. And if the pain is still persistent, think of conditions like ectopic pregnancy, infection, or incomplete miscarriage. Nausea and vomiting usually are self-limiting. You can reassure her. Diarrhea is also the same, self-limiting. Just reassure her. Infection, you have to confirm by your clinical examination, and you start giving her antibiotics. So if there is a failure of medical methods, you can either repeat the medical methods or offer her vacuum aspiration. So you observe her. If she is not bleeding heavily, you can give her again, repeat her MMA. If the bleeding is very heavy, you may offer her surgical method of evacuation. That is a failure, or in incomplete cases, you can do either. The option is to either repeat the medical method or offer her vacuum aspiration. If it is incomplete and the bleeding is not heavy, you can just observe her. So whenever there is a excessive bleeding and more than a menstrual cycle, and she says that she is soaking 2 pads in 1 hour or for 2 consecutive hours, and it continues to be heavy, then it is very important. Then you continue watching her vital signs. You do a pervaginal examination and feel for the products in the cervical canal. If they're in the cervical canal, evacuate it digitally. If the bleeding is not high, keep a watch on the vitals and then end amount of bleeding. And if they're not very heavy, you can send her back home. If the woman is stable and the bleeding reduces, then you record the vital signs and bleeding pervaginal for 1 more hour. Otherwise, you do an ultrasound, and if there are minimal products, you can wait and watch. If there are considerable products and the woman is stable, repeat with meso. If she is not stable, do a vacuum. And if she is continuing the pregnancy, do not, you have to do a vacuum aspiration. So it is very important not only doing it in the right way, but also recording and reporting. Even if it's a medical method of abortion, all of them have to be recorded and reported to your district head, that is the DM and HO. So it comes under the purview of MTP Act. So the documentation is similar to the vacuum aspiration procedure. You have to fill the consent form, the RMP opinion, the form 2 monthly reporting form, as well as the admission register for case records. All the 4 forms have to be completed as per the protocol. And other than the medical methods, we also have the surgical methods for evacuation in first trimester. One is the vacuum aspiration, that is for up to 12 weeks. And manual vacuum aspiration is supposedly the safest method, and you should not do a sharp curettage, as we've already discussed. So the procedure of abortion performed is the same, whether it is manual or electrical. In manual, you have the MVA one. All of us are very familiar with this MVA. That has a handheld aspirator which creates a vacuum, and there are different sizes of cannula which can be used. The IPAS or easy grip cannula, the size corresponds to week of gestation, and I think from long time we have been using that. The advantage is that it doesn't need any electrical supply, whereas the electric vacuum aspiration needs an electric pump which creates a vacuum. And again, there are different cannulas. Whether to do cervical priming or not, it is advantageous to make it soft and easy to dilate. And different methods in the first trimester are oral mifepristone 200 milligrams, misoprostol 400 micrograms sublingually 2 to 3 hours prior to the procedure. If it is Mifi, give it 1 day before. If it is Miso, just give it 2 to 3 hours prior to the procedure, either sublingually or vaginally, 400 micrograms. Or if you want, you can place a laminaria intracervically prior to the procedure. So when you're doing a vacuum aspiration, pain is, you have to take care of the pain, and it can be non-pharmacological or pharmacological, by giving her psychological support, explaining the steps, performing the procedure gently, and encouraging her to relax and breathe. If you're going for the pharmacological pain management plan, depending on the source of pain, your treatment is, if it is because of anxiety, give her anxiolytics or GA. If it is cervical dilatation which is causing a pain, you can give local analgesia with lignocaine. The 10 ml of 1%, a paracervical block we usually give. Analgesics like ibuprofen can be given 400 to 800 milligrams 1 hour prior to the procedure, but they have side effects. Uterine cramping is causing pain. You can give her again ibuprofen. and it can cause gastritis. So MVA steps, I think these steps we're all well versed with, how to prepare the instruments, the woman, and use antiseptic preparation. And you give a paracervical block, dilate the cervix, and then insert the cannula. Just withdraw the cannula from the fundus, and then you rotate the cannula with the smooth, gentle motion, and then release the vacuum button on the aspirator. So what tells us that the uterus is empty is, again, is a very, we all know, red or pink foam without any tissue coming in, gritty sensation, cervix grips over the cannula, uterus contracts around the cannula with increased uterine cramping. Then you have to inspect the tissue, and concurrently, if she wants any sterilization like our IUCD, you have to go ahead with it. And of course, cleaning and taking care of the instruments is an important element of any surgical procedure. I think, post-procedure, you monitor her for any complications and provide management as needed. She can leave the facility when she is stable and meets the criteria for discharge. You should give her all the necessary information and medications before she leaves the facility, and document all the outcomes of the treatment, including if there are any adverse events, in the facility register and also on the client's record card. So it's very important to document everything that goes right, and sometimes if anything goes wrong. So aftercare, you have to manage the complications if there are any, and give her contraceptive information, give her all contraceptive counseling, and give her the advice regarding the methods. And any other associated sexual and reproductive health needs of the women should be catered to. And no need of any routine follow-up unless it is a meso alone regimen, as we have already seen. So to summarize, we had India as a country has made historic progress in improving access to safe abortion. Nothing much has changed in technological update in the last decade. As providers, it is up to us to ensure safety and quality, especially in context of the amended law. Along with safety, we also need to focus on respectful abortion services. And every client, whether she's public or in private sector, has an opportunity should have an opportunity to be informed, educated, and equipped with proper information on both contraception and counseling. Maybe the next most important point we should add is proper documentation, and monthly information is again very, very important. I hope you're all taking your pre and test. We have all taken your pre-test, and at the end of the next last module, you will be going for your post-test, and then you will get your certificate. And we are fortunate to be in a country where the country recognizes the need of the women and tries to make the abortion as both legal, safe, and also respectful. Thank you all for your patient hearing. And I hope I could add something to already. Most of this has already been there in your what you have been following. Thank you.
Thank you. Thank you so much, Krishna Kumari. You have had a marathon session from Moradabad, Meerut, Jhansi. One here. Thank you so much. Before we move on to the last presenter of the day, Savita, can we take 2 or 3 questions which are there, since we have the benefit of Krishna Kumari and Lakshmi, both of them being here. One of the questions was by Renuka. No, there's one by Neha. What is the upper gestational limit to do MTP in a married or unmarried couple with failure of contraception?
The failure of contraception per se is doesn't matter whether they are married or unmarried. That is the most important difference that it has come into our armamentarium, is whether it is, we are not going to ask the woman about her marital status. Just as any woman or any partner is eligible for termination of pregnancy. That's the first thing. The second thing is upper limit is up to 20 weeks as per the regular for any termination of pregnancy can be done by a single individual. But between 20 to 24 weeks, if they fall under the 7 criteria, which we call as vulnerable group, then yes, they can go, you can go up to 24 weeks and give them we can permit them for termination of pregnancy. And of course, when there is a fetal anomaly, the upper limit has been removed. I hope we could answer her question.
Thank you. There's another question by, so I hope that answers your question, Neha. Another question by Renuka. Unmarried girl more than 18 years, if after pills or MTP complains against partner stating it was non-consensual act, then where do we stand, as we have only her consent for termination? Is any more documentation required?
If it is more than 18 girls, it is the woman's right. If you have filled up all the 4 forms appropriately, which we have just spoken about, and you have reported it, and she has signed and given her consent, that's it. I think we are legally clear.
Thank you. Hemlata has 2 questions. Few hospitals registered up to 12 weeks of pregnancy for MTP don't allow termination of pregnancy for intrauterine death about 12 weeks. They feel scared. Can it be done at such a hospital?
No, for IUDs, I think there is no upper limit. Why they're scared, I don't understand that, because that doesn't come under this MTP Act at all. If there is an intrauterine death, it's an entirely different scenario. If the particular place where it is, where you're planning to do the procedure is equipped for all the labs and all the methods and all the consequences of IUD, then I think that should not come under the MTP Act at all.
Okay. On follow-up after medical method, is sonography compulsory to confirm completion for abortion, or only negative urine pregnancy test is enough if patient has stopped bleeding or spotting?
See, the recommendation goes like this. The recommendation says follow-up is only by clinical examination, and they have left it to the discretion of the gynecologist to decide whether you still are, if you think you're suspecting ectopic pregnancy or infection or any other incomplete abortion, then only they're asking even for a follow-up, do a pelvic examination and do a ultrasound. Otherwise, they are not asking you to follow up also, except if you are given only misoprostol. If you have given gone by the regular protocol which we are following in our country of MIFI and misoprostol, they are not even asking us that follow-up is mandatory. So it's absolutely the discretion of the gynecologist, where you are suspecting that it is beyond normal healthy pregnancy, or you're suspecting it could be an ectopic, or you are suspecting products to be retained, then please go ahead and do the ultrasound, or if your facility is available, but it is not mandatory. Your voice is not there, Ajay. I think you muted yourself.
Yeah. Last 2 questions are there. What about medical abortion in LSCS patients?
That's technical. There is nothing, there is no law against it. So that it's a technical issue which we have to, which we are facing with one LSCS. Yes, we are doing with more than one LSCS, it becomes an issue. So that's how it goes. There's nothing specifically said in the new law regarding LSCS. As far as books go, yes, there are, has its own complications.
The next one is an interesting one. If medical method offered to a patient without ultrasound and later it is diagnosed as ectopic, isn't it a negligence on our part to go ahead with MTP without ascertaining the site of pregnancy?
That's exactly the point, Doctor. I think this is from Dr. Shubhra. So that's this question keeps propping up time and again every time we are making this presentation. Yeah. So what we are again telling is there is nothing to say do not do an ultrasound. See, if you remember the first module, the main concentration was to make it available for every woman at every crook and corner of the country. So even if there is a single obstetrician in a PHC who does not have an ultrasound machine, she has also been given the right to do a medical termination of pregnancy by medical method, even if she's alone. That was the whole purpose of bringing this RAC, the main thing which was brought about in this RAC. If you have a facility where you want to do a ultrasound before you do the procedure, there is no rule against it. But if you are, but from what the law says, yes, they do. These women where there are no facilities, and still a woman in a periphery over a very remote place need not go only for the sake of ultrasound to a center where there's an ultrasound and go ahead with the termination. That is the whole purpose. I think we should take it in that way.
Hold on. Yeah, and there's a last question now, I think so. Megha is asking, ma'am, what is the use of BHCG done for incomplete abortion?
Urine based in HCG, urine pregnancy test remains positive even after 2 weeks. So if you do it after 2 weeks after doing a termination, your test is positive, you are going to get worried, your patient is going to get worried. So please do not, I don't recommend doing any, whether it's urine or serum beta HCG after to know whether it is complete or incomplete. Take a proper history. If the patient says she has past products, she had heavy bleeding, then the bleeding has come down. Yes, one indicator. Do an internal exam. If the cervix is closed, if she had the regular bleeding, now the bleeding has decreased. Clinically, your cervix is closed, uterus feels normal. Again, you have an evidence. If you have an ultrasound, okay, check with an ultrasound and see if it is complete or not. I think these are the different ways of assessing: by history, by clinical examination, and by ultrasound. I think the HCG is not a way to go about to identify whether it is complete or incomplete. I think we are done with the questions.
Okay, thank you. Yeah, I think with that, we come to the end of the
one second, Ajay. Dr. Rekha wants to know about the books, which can, these books are not, they're very huge volume. I mean, there are quite a lot of material in that. That is just makes for interesting reading. Whenever you just go onto the website and click on WHO guidelines, there you get a whole series of books. You can choose what you want to, how much you want to, and how much time you can afford to spend on the books. What this modules are saying, what modules are saying is a concise, focused form. So what is necessary as a clinician, we are trying to bring it to the every Foxian. That is the purpose of this whole meeting. So Rekha, if you want, you're interested, just go and click for WHO guidelines. You'll get a whole lot of books.
True that, yeah.
Okay.
Good evening,
sir. So
sir.
much for being so patient in replying to all of this questions, Mr. Kumari. It's absolute pleasure to have you. And Savita, thank you for your patience to hold on. Yeah, I know you're also anxious to complete everything. We are running at 10 to 15 minutes late. But
Good evening, sir. Good evening.
Yeah, good evening. Over to you. Please carry on with the next session. And the last part of today's.
Should I share the screen?
Yes, please. You're already the co-host.
Yeah, thank you. Thank you, Ajay. Thank you, everybody.
Is it tablet?
Yeah, we can see your.
My screen is visible?
Yeah, it's visible. We can see your email with a lot of passwords there. You'll have to get to here. Now we can see it. Yes.
Okay, sir.
Yes, you're set.
Thank you, sir. So this last module is on the pre and post abortion care, although madam has covered a lot in her module, but I have to say, cover this part of this RAC training program. So that it is very important to do the counseling about the family planning when the patient comes to us at the time of abortion, because at that time patient is very much sensitive and they are very much ready to adopt these family planning methods. So counseling is very much important. And as said, counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. So what are the parts of this pre and post-abortion counseling? First part is the integral part of comprehensive abortion services, which we have to provide. Then it is as important as the procedure, and women may need help in decision making. Sometimes the woman is very much confused what to take and what to not take. So we have to help, and we have also take the spouse at the same time when we are doing the counseling. So the decision making becomes easier for her. Then procedure counseling critical roles, there are help, ensure, and help. First help is help women decide about termination of pregnancy. Second, help women to choose the method of termination. Third, ensure delivery of complete information. About the procedure, and third help is help women to adopt a contraceptive method. And what is the pre-procedure counseling and what are the procedures? We have to provide her the privacy. When we are counseling one patient, we should not allow the another one to enter our this chamber. That is very important. So the patient comes in the confidence. Second, we should not be the non-judgmental and be very sensitive. And we have to establish the rapport between us and the patient. That is also very important. So the patients have faith in us. Then use the simple language so that patient is able to understand the things and she can clarify her doubts about the contraceptive methods. So it is very important. And if she has made up her mind for termination of her pregnancy, assess her for the procedure. Then what is the relevance of peri-abortion family planning counseling? It is very important because patients return of fertility is very quick after the abortion. So we have to, it is very important to talk about the contraception, and it is the opportunate time for the contraceptive acceptance. And there should be at least 6 months gap if she is planning for going for another pregnancy. It is not only for the benefit of her health, but also for the better future pregnancy outcome. And it has been seen that 90% of abortion-related maternal mortality can be prevented by ensuring the contraception. Then what is the pre-abortion family planning counseling and when to start? As soon as patient comes to us for the consultation about the MTP, we have to also counsel about the family planning methods. But if the patient is a case of a rape or she is a widow, then we have to avoid it. And what to counsel? We have to counsel her that if she is not taking for any contraception, the fertility may return within 10 days to 4 weeks. And we have to help her with the choices. We have to put all the basket of the contraception in front of her. And we have to ask her method specific counseling. And we have also high risk behavior whenever possible. The women is not, even it is very important, if she is not willing for the anti-contraceptive method, we should not deny her MTP. We have to go for the MTP. Then we have how to assess the suitability for post-abortion contraception. We have to see if the procedure is complete, if there is no infection, if there is no injury to the genital organs, and there is chances of any fresh pregnancies are ruled out. So we have to take care of all these things when we are asking for the contraception to the lady. Post-procedure counseling is having a very critical role. It ensures women has understood precautions and care needed during post-abortion period, opportunity to counsel for contraception in case not previously accepted, and reinforce the need for continuing the use of contraceptive methods chosen. If she has already chosen, we have to reinforce and her counselor, because sometimes they come again, this method is not suiting or my husband is not willing. We have to reinforce her. Then what is the post-procedure counseling and what is the procedure? She has to continue to ensure privacy and confidentiality even if she is coming after the abortion. Reassure her in case of any problem. Repeat the information about post-procedure care and the danger signs. If she has already opted, then appreciate her. Give her immediate care like IUCD or FPA. If she has come for IUCD, we have to give the IUCD, or if she wants hydroxyprogesterone acetate, we have to give that injection at the same time. If she is on the oral pill, she has, whether she is continuing or not, we have to take care of that also. And we have to ask her for the follow-up protocols has to be talked with her. And continuity is very important. And we have to provide the cards so that she can remember when she was given the IUCD or the next injection of the method hydroxyprogesterone acetate is due. Then if she's undecided, then we have to allow her anxiety. We have to counsel her that there is so many methods and there is no, every method is not having side effects. We have to allay her anxiety. We have to give her the importance of immediate adoption and chosen, and extended period of adoption should be provided to her. And we should also take the her partner along with her when we are doing the counseling. And we should also ask for the emergency contraceptive pills if she is not willing for taking anything. Then we have to also ask her for the emergency contraceptive pills. What are the post-abortion contraceptive methods? That can be variant methods. It can be that these are the condoms. These can be given after the first trimester abortion as soon as the patient is sexually active. Second trimester abortion as soon as sexual activity is resumed. And we have to give the information to the patient that it is non-hormonal, so hormonal side effects are not there. It can be used even without consulting a health provider. It is available over the counter, prevents against sexually transmitted diseases, including the HIV, and enables men to take responsibility of contraception. Second method is Intra Iucd. These intrauterine contraceptive devices are maybe 380 or 375. It can be inserted immediately or up to 12 days after confirmation of a complete abortion using the surgical method with medical method of abortion. Inserted around day 15 of the process, provided complete product of conception expulsion is confirmed and risk of presence or infection or any other contraindication are ruled out. In second trimester abortion, it can be inserted immediately or up to 12 days after the procedure is complete, and there are no contraindication to insert it. And what are the additional information? It is highly effective. It provides long-term contraception for 5 years if it is IUCD 375 or 10 years if IUCD 380 is inserted. It can be provided by trained doctors, MBBS and above, A&M nurses after first trimester surgical abortion, and trained doctors only after medical method of abortion, and by PPIUCD trained doctors after second trimester abortion. A&M and nurses can insert if it is the medical method of abortion, but if it is the second trimester abortion, only the qualified doctors can insert it, and there is no interference with the sex, and patient immediate returns to fertility as soon as we remove this IUCD. Then the hormone contraceptions. These are the COCs. First trimester immediately or up to the 7 days after abortion using surgical methods. With medical method abortion, it can be started on day 3 when we are giving the misoprostol, or within day 15 of the process after confirmation of the complete abortion. In second trimester, immediately or up to 7 days after the abortion. It not only regulates menstrual cycles, it can be provided by all health workers after first screening by trained providers. It doesn't interfere with the sex. It not only protect against the ectopic pregnancy, but also against the endometrial and ovarian carcinomas and benign diseases such as fibrocystic and fibroadenomas. adenomyosis. It is not suitable for the women if she is breastfeeding and babies are less than 6 months of age. Then the hormonal contraception, the long-term injectable medroxyprogesterone acetate. It can be given after the first trimester abortion, up to the 7 days after abortion, or using the surgical methods. If the patient is having medical method of abortion, it can be started on day 3 with the dose of misoprostol. And the second trimester, immediately or up to 7 days after the abortion. It is highly effective. Confidentiality and privacy are maintained. Can be provided by doctors, whether these are MBBS or IUs, ANMs, nurses. Also can give it after the screening by the doctors. That screening should be done by the MBBS doctors for the first injection. And it also doesn't interfere with the sex. It has no effect on the quality and quantity of the breast milk, no estrogenic side effects, and there is no also protects against the ectopic and endometriosis and fibroid also. Then there are some permanent methods of contraception. It can be female sterilization or vasectomy. Female sterilization, if patient has first trimester abortion, it can be performed after an abortion in the absence of any infection or severe blood loss. Concurrently or up to the 7 days, both mini-lap or laparoscopic sterilization can be done. With medical method of abortion, it can be done only after the first menstrual cycle to ensure that the abortion was complete. The second trimester abortion, mini-lap sterilization can be performed concurrently or up to the 7 days after an abortion in the absence of any infection or severe blood loss. We have always to check for the infection and the blood loss. And laparoscopic sterilization is not recommended. What are the additional advantages of female sterilization? It is a permanent method, highly effective. It effective immediately after the sterilization procedure has been done. It doesn't interfere with the sex, no impact on breastfeeding, no long-term side effects, and it offers protection against ovarian cancer also. Vasectomy performed on males, independent of the timing and procedure of the abortion, and it is very effective. And it is very effective. Then, what are the contraceptive methods with the medical method of abortion? On day 3, we can ask her to take COCs. Injection can be given. Scent woman can be advised on day 3. The patient is going for vacuum aspiration. Then COCs can be given at the same time. Injection can be given at the same time. Scent woman can be advised at the same time. IUCD can be inserted at the same time, and ligation can be done at the same time. What are the teleconsultation and other technology? Because in this era of this COVID, we have gone through so many webinars and all these teleconsultation also. So if patient is available, want to do the teleconsultation, we can provide her these do the counseling, can guide her on the telephone, and we can also provide her these, ask her to go through these websites like Hamdo, social media like Ask Tanu, YouTube, infographics. We can provide her helpline numbers as we, after giving the medroxyprogesterone acetate, we always give her one helpline number. So if she having any problem, she can talk at that number. And we can also provide some patient education platform like WHO, MOH, FW, and RCOG. So what is SWOT of teleconsultation? It is a strength, weakness, opportunity, and threat. What is the strength? When there was a COVID era, then it was easy to do on this online consultation. It is approachable throughout the process. There was patient having the confidence. There was awareness, spread out questions answered at each. But what was the problems? Because there was no face-to-face talk. So, and we cannot demonstrate the methods in front of her. And opportunity was that privacy was maintained, and it was comfortable because patient was at home and we are doing it, and it was cost saving, and there were number of patients were cut down. But that sometimes opportunities were missed and misdiagnoses were made, like patient may having the ectopic pregnancy or have some infections, so that could have been the missed. So what are the applicability of components of CAC? That assessment, confirmed diagnosis, contraceptive need, counseling is very important by video conference, but through video conferencing or through the Zoom, and follow-up. So we can provide the hybrid services to the patient. The patient may come to us on the first visit, inspect, and we can examine her, can ask her to and prescribe her the medicines, and then we can go for the teleconsultation to the patient. So key messages are: realize the need of post-abortive family planning methods, bring the couple on board, and strive for 100% coverage, capitalize on the basket and applicability in post-abortive period, technology, use the technology if possible, scope for entry in CAC services is there, concerned policy, malpractice, service, costs, and assess. Adolescent RS need both online and offline are important. So it is important. I think all have done the pre-test registration, and now post-test will be there and feedback has to be given. Then only all the attendee will get the certificate. Thank you, sir. So let us make it safe and respectful to all women. That's our aim. Samarth Bharat, Sampoorn Bharat.
Thank you so much.
Thank you, sir. Thank you, sir, for giving me this opportunity. Thank you so much, sir.
Always a pleasure. Can you stop sharing the screen? We'll just take another 5 minutes or so, and we'll call this meeting to an end. Lakshmi, are you there? Lakshmi? You're logged. I can see you logged in, but I don't know if you're. Okay. While we get Lakshmi online, Savita, can you just address these couple of questions here?
Yes, sir.
One is, can we insert copper T while doing evacuation for retained product?
Yes, we can insert the copper T, but we have to look out if is there any chance, if there is any sign of infection, then we have to avoid. If it is clean cut, then we can insert the copper T at the same time.
Okay. Then there is one more question. Blighted ovum and incomplete abortion, missed abortion also need full paperwork to be done as an MTP?
Sir, what is the question?
Blighted ovum. Let me just put the question here.
Blighted ovum, incomplete abortion, missed abortion also need full paperwork to be done as any. No need. No need.
No need.
Because these doesn't come under the MTP Act.
Yes. The last question for the day is, unmarried women below 18, can MTP services be given without informing parents? If she has any complication, won't we be legally responsible?
We have to inform the, it is very important to inform the police. At the same time, I think sir, I think the parent should be there along with her.
Okay.
And we have also to an information to the police is also important if she is made less than 18 years of age.
Yes.
Both are required.
Less than 18, it comes under POXO, and therefore all mandatory requirements of reporting under POXO has to be followed. Okay. As far as informing the parents is concerned, there has to be some consent that has to be taken either from parents or from a guardian who's accompanying the less than 18 woman, and let the law follow its own course without denying her the abortion services. Okay.
Any more questions, sir?
One more is there. If more than 18 but unmarried. If more than 18 and unmarried, married and
sir,
unmarried.
put the question above.
Yeah. Somebody is posting directly to me.
Okay.
If more than 18 but unmarried, in that case, what is to be done? If more than 18 but unmarried, marital status has no consequence on providing abortion services. Okay. And if it is more than 18, her own consent is good enough, unless there is some other person accompanying her who's an adult, his or her consent can also be taken. Please tell about POXO again. POXO, I'm sure everybody here in the group is aware of a POXO Act, which is for less than 18 individuals who have been, been in a compromising situation with either a rape or not a rape, or some kind of force or some kind of, coercion over there. And in all these cases, one needs to inform the police either which way and complete the entire processes related to informing under those laws and rules. Guardian means blood relative, not the partner. It could be a partner also, so long as a partner is an adult. What is the upper gestational limit to do an MTP in married or unmarried couple with failure of contraception? Would you
20 weeks. It has been. It is 20 weeks.
Till 20 weeks.
If the failure of contraception is there, then it is only up to the 20 weeks. But if patient is widow, or it is by rape, or some other that is malformed baby, widower going for it has happened by the rape, then we can go up to the 24 weeks. But in cases of this malformed baby, there is no limit. But after 20 weeks, 2 RMP should be there if we are going for MTP.
With that, thank you so much, each and everyone, for being part of this. I have just posted the post-test and feedback link in the chat box. And thank you very much, Savita, for taking on the questions and handling all of them. Just click on the link. Another box will open up, which will allow you to submit your pre-test and post-test.
Thank you, sir. Thank you so much.
Requesting all participants and members here to please click on the link and submit your post-test. I'm posting it again for the benefit of everyone in case you have missed it. Click on the link and submit your post-test. So have a wonderful evening, each and every one of you. Thank you all the organizers for having made this possible for us to come and attend this. Thank you so much, all the faculty, with Krishna Kumari, with Lakshmi, and with Saileja earlier, and Savita for having walked us through this entire wonderful program, which had a lot of learnings and a lot of feedback to take back. Thank you very much, each one of you.
Thank you, sir. Thank you so much, sir.
Have a lovely evening, everyone.